Hey everyone, let's dive right into this explainer and rapidly master the pathophysiology, presentation, and management of posterior reversible encephalopathy syndrome, better known as PRES. Whether you're hitting the wards or prepping for the boards, this is one of those sneaky topics that loves to show up when you least expect it. But don't worry, getting a solid framework down today is going to make diagnosing it an absolute breeze.
Okay, picture this classic USMLE style scenario. We've got a 32-year-old pregnant female at 36 weeks presenting to the ED. Her blood pressure is literally through the roof at 190 over 110. Suddenly, she has a generalized tonic-clonic seizure, and upon recovery, she's experiencing cortical blindness. So what's the diagnosis? Now, if your mind instantly jumped to eclampsia, you are definitely on the right track. But we need to go just one step further to understand the specific neurological syndrome that's actually unfolding in her brain. And that underlying syndrome? It's PRES. By definition, it's a clinical radiographic syndrome characterized by vasogenic edema, typically affecting the subcortical white matter of the posterior cerebral hemispheres. Honestly, the name itself is kind of funny because it's a bit of a misnomer. As you're going to see, it's actually not always 100% reversible, and it's definitely not strictly confined to the posterior regions of the brain. But hey, the name stuck, so we really need to know exactly what it entails. Section 1. The why, pathophysiology and causes. Right, so we need to contrast the two main competing theories behind why this fluid leakage actually happens in the brain. On one hand, we have autoregulatory failure. Normal brains are usually incredibly good at keeping blood flow constant. But when systemic blood pressure spikes to extreme levels, it just completely exceeds the upper limit of your brain's autoregulation. The arterioles dilate, blood flow surges, and you get this massive brain hyperperfusion that literally forces fluid out into the surrounding tissue. Now, on the other hand, we have endothelial dysfunction. In this scenario, circulating toxins or inflammatory markers cause direct physical damage to the blood-brain barrier, so the capillary leakage happens directly, even if the patient doesn't have massively high blood pressure. Because of these two mechanisms, certain patients are at an incredibly high risk. You absolutely must memorize these classic triggers. Hypertensive emergencies, of course, naturally trigger that autoregulatory failure we just talked about, but pay super close attention to eclampsia, preeclampsia, and calcineurin inhibitors, things like cyclosporin and tacrolimus. These are massive, high-yield exam buzzwords. Like, if you see a transplant patient on cyclosporin who suddenly gets confused, think PRES. A patient in renal failure with massive fluid overload, yup, think PRES.
Section 2. The what? Clinical presentation.
It's actually really cool how we can map the classic triad of symptoms directly to the underlying anatomical disruptions in the brain. So when that edema hits the highly susceptible occipital lobe, you get visual disturbances. This can be anything from blurred vision all the way down to complete cortical blindness, sometimes even with visual denial, which is known as Anton syndrome. When the fluid leaks out and causes cortical irritation, bam, you get seizures. And when the edema is more global or diffuse, it causes constant, non-localized headaches and altered mental status. That can range from just mild confusion all the way down to a stupor. Speaking of those symptoms, I really want to highlight this number, 75 to 90%. That massive percentage represents exactly how often PRES patients present with seizures. It's an incredibly high-yield diagnostic clue. These are typically generalized tonic-clonic seizures, and honestly, they are very often the very first thing that actually brings the patient into the emergency room in the first place. Section 3. The how, diagnosis, and neuroimaging. Now, while a non-contrast CT scan might be done first in the ER just to rule out a massive bleed, you've got to remember that MRI is the absolute gold standard for diagnosing PRES. Specifically, you want to be looking at the T2-weighted FLAIR sequences. What you're hunting for are bilateral, typically symmetric hyperintensities, those bright white patches, predominantly showing up in the subcortical white matter of the parieto-occipital regions. Okay, listen up, because here is the single most common exam trap you are going to face. You must confidently distinguish PRES from an acute ischemic stroke, like a top of the basilar stroke. Remember, PRES involves vasogenic edema. Fluid is leaking outside the cells. On an MRI's diffusion-weighted imaging, or DWI, this usually shows up as hypointense or isointense. An ischemic stroke, however, involves cytotoxic edema. The cells are actively dying and swelling up. This restricts diffusion, so it shows up as brightly hyperintense on DWI. Trust me, knowing this one imaging difference is going to absolutely save you on test day. Section 4. The action. Management and prognosis. All right, acute management requires 3 rapid steps. Step 1 is blood pressure control. But wait, this must be careful and incremental. You want to aim for a 10 to 25% reduction initially, using easily titratable IV meds like clobidipine or labetalol. If you drop their blood pressure too fast, you actually risk causing true cerebral ischemia. Step 2, remove the trigger. If it's cyclosporin, stop the drug. If it's eclampsia, you've got to deliver the baby and the placenta. And step 3, manage the seizures with appropriate antiepileptics or, of course, magnesium if we're dealing with eclampsia.
The good news? With prompt action, the prognosis is usually excellent. It's typically completely reversible within just days to weeks. And interestingly enough, the clinical recovery, meaning the patient actually waking up and feeling better, usually precedes the radiologic resolution on their MRI. But a quick warning here, if you miss this diagnosis, that vasotomic edema can compress the microcirculation and lead to totally irreversible infarction, or worse, hemorrhage.
Section 5, High-Yield Clinical Pearls.
Let's rapidly hit these final takeaways so they stick. 1. It's vasogenic, not cytotoxic edema. 2. It has a strong parieto-occipital predilection, though, yeah, it can show up elsewhere. 3. Its reversibility and unique imaging profile easily distinguish it from a stroke. And 4. Always watch for it to be triggered by immunosuppressants like cyclosporin or during pregnancy with eclampsia.
Finally, let's lock in this golden rule of thumb. Whenever you see a patient with new-onset seizures, significant hypertension, and visual symptoms, you absolutely must think PRES. This triad burns the core clinical picture right into your brain. So the real question is, will you spot these overlapping clues before irreversible damage occurs? Thanks so much for joining me on this explainer, and definitely keep these concepts top of mind the next time you hit the wards.